Welcome to another episode of the Federal Newswire Lunch Hour Podcast with your host, Andrew Langer.
Well, hey there, everybody. Welcome to another episode of the Lunch Hour with Federal Newswire. I'm your host, Andrew Langer. And, if you're watching us on YouTube, you can take the Lunch Hour wherever you go on one of the many fine podcast platforms at which you find our content. And if you're listening to us on one of those podcast platforms, you want to check out what we look like here in the studio, you can go and visit our YouTube channel. As always, please leave a like, a comment, a subscribe, and let everybody you know how much you're enjoying the Lunch Hour. Now, a topic that is near and dear to my heart is the state of American healthcare. You all know that I, in addition to running the Coalition Against Socialized Medicine, I've been married to a family physician for many, many years. So these are issues that are near and dear to my heart. Joining me today is someone I've been eager to bring on. Her name is Dr. Marion Mass. She is a dedicated pediatrician, community volunteer, writer, and healthcare advocate. She has her MD from the Duke University School of Medicine, laying the foundation for her career in pediatrics. As a mother, Dr. Mass balances her professional responsibilities with her family life, demonstrating her commitment to both her patients and her own children. Her passion for healthcare advocacy, and this is the primary reason why we're having her on, led to her co-founding the Practicing Physicians of America, an organization aimed at improving the healthcare system. She's also involved with Avery's Hope through the there we go. Anyway, the bio that I put up there. As a writer, she contributes her medical expertise and insights to various publications, helping to educate the public on important health issues. Dr. Mass's multifaceted approach to her career showcases her dedication to not only treating her patients, but also addressing systemic issues within healthcare. Her work exemplifies the intersection of clinical practice, community engagement, and policy advocacy in modern medicine. And Dr. Mass, thank you so very much for joining us today. And let's start here. What made you decide to take the leap into doing this kind of policy advocacy in addition to your clinical work, or was that something that was always a part of the work that you were doing?
How funny. People will appreciate this, especially the moms out there. I'm sort of almost like a combination of Clouseau and Forrest Gump in advocacy, right? I made the very conscious choice to stay home with my children and work as a hospitalist, mostly nights and weekends. I'm married to a surgeon. We balanced it. We kind of had, we saw each other coming and going for a while. And I worked part-time. When the kids were old enough that I could have done more in terms of hours of clinical stuff, I took a look around and it's like I was like Rip Van Winkle waking up. Like, what the heck happened to medicine? I mean, it was terrible. There were so many more mandates and things that we had to do, hoops that we had to jump through. Your wife knows all this, right?
Yes.
And I'm a pediatrician. She's a family practitioner. Pediatricians are the bottom of the pay barrel. So was I going to now work full time, get gray hair faster so that the government could take most of the lowest salary in all of medicine? Well, no. So then I started thinking well, maybe I could do something about this to change it. So I started looking into it. And then I bumbled into to fast track my thought process. It's like, well, healthcare is messed up because it costs too much. We're all getting less and paying more. And so it's the economy, stupid. So look at where the money's going. And I started following the money trail. And I ran right into behemoth conglomerate corporations. We have this weird medico-politico, actually even academic industrial complex in healthcare. Right. And your children and my children are going to get chewed up by this if we don't do something.
So it's interesting because I was not a healthcare policy guy. I was always on the regulatory side of things, even with my wife being a physician and even with the policy work that I was doing. And then I'll never forget this. We're driving up the New Jersey Turnpike, and as it happens on our trips, my wife tends to bring her issues of JAMA with her, the Journal of the American Medical Association. And she turns to me and she says, we have a massive gap between the number of physicians that we have in America and the number of physicians that we need. And this is not getting any better. In fact, the problem is getting worse. And given certain policy determinations that were being made, it's only going to continue to get worse. And I said, but boy, This is really interesting. This is a resource economics problem, because I was working for an organization at the time that was focusing on trying to find ways to deliver greater HMO services to a wider variety of constituencies. And I'm like, well, this isn't going to help, because regardless of if you go a single payer government run healthcare system, or if you go down the road of a massive, everybody gets an HMO system, at the end of the day, the end result is still the same. Fewer doctors supplying more patients in less time. How is that going to work? I mean, I think you came to you're inside it. So what are your thoughts in this vein?
Oh, it's a mess. And actually, one of the things that I'll say too is like, yes, it's true. We have fewer physicians than we need, but what the public really has is less of physicians' time than they need, right? Because we're so busy doing all the regulatory, I call it the glut. Cut the glut of like the regulations that are causing us to not spend time with our patients. I mean, my gosh, it used to be, I think for a sick visit, you would get 20 minutes and a well visit, you'd get 30 minutes, and it's down to like 7 and 15 respectively. But who's going to take the place of your wife, me, and others when, like, look at the tuition. I mean, I'm painfully aware. 2 kids done college just recently. 3rd kid about to start his junior year. Oh no, thank you.
We have a junior in college as well. One just graduated from college. So yeah. So I'm sorry. Go ahead.
Congrats to you too.
Thanks.
Like, you're almost done. But there's our 3 children, and I'm married to a surgeon, and none of them are going into the practice of medicine.
Yeah.
I mean, I've had this conversation. Actually, one of my favorite senators, U.S. Senator Roger Marshall, he's an obstetrician. And truthfully, like, he's become a friend, because we agree on a lot of things. His wife is a nurse. They're very dedicated. They have 4 children. No one's going into healthcare at all.
Well, it's interesting because, my younger one is going into, wants to be a doctor, is working as a scribe in an ear, nose, and throat practice this summer, and did last summer as well. So she's very interested in these things. But you're absolutely correct. My wife comes home and tells stories about, nurse practitioners who are a vital aspect of any medical practice today, who are getting out of it to go into sort of the fee for service, well, it's not voluntary. What's the word I'm looking for? When medical care that you want to take on,
concierge versus or direct pay care,
but also like cosmetic medical care. I mean,
So I see what you're saying. Yeah.
So it's a situation, and I'm sorry, I'm just having these brain freezes every once in a while. But that's the problem, right? Is that obviously, when you have more folks going, and you can imagine going for the fee for service kind of stuff. And you're right, with medical schools being as expensive as they are, you come out with $400,000 plus in debt. And the only way that government and HMOs can recoup costs is by lowering reimbursement rates. You can't make ends meet unless you're seeing more and more and more patients. And that has its issues. Let's start here, because this is something my wife and I spend a lot of time talking about. Because as she points out, we could increase the number of medical schools in America, but if we don't increase the number of residency programs in America, and those are almost all funded by Medicare, then it doesn't help the situation. What are your thoughts here?
Oh yeah, I got a lot of thoughts, and actually, I'll direct you to. I started Practicing Physicians of America, and then we formed the Free to Care Coalition. Free, the number 2, and then Care. Free to Care is actually 8 million citizens, 70,000 of them are physicians, aligned behind the ideas in our report, which is right on our website. You can look up the report. So now anyone who's listening, if they want to go look at the report and all the stuff, on middlemen and transparency and how do we get rid of the physician shortage or the shortage of time, it's all in there, right? But in addition, there was a part about the residencies. And one of the things that I think people don't realize, I'm so glad that Medicare funds the residencies. There's no transparency on where that money is going. And I may get the numbers a little wrong, so someone can go back and correct me, because there's a lot of numbers in that paper, a lot of charts, a lot of graphs. But the average amount that Medicare pays a residency program is somewhere like about $110,000. And as you know, residents are nowadays they're making about an average of $60,000. They have to pay their own living costs, housing costs, all the rest of that. Now, there's a little bit of money that goes towards their insurance and such. No one pays the attending physicians to teach.
Yeah.
But where's the rest of that money going?
Right.
And now it's not just that the hospital that's doing the residency collects that 110 per resident per year average. Some of them it's much more. But they also get to bill off of that resident as they're practicing. So for the hospitals, this is like, no one ever talks about how much they're billing off of the residencies. And, you know, residents themselves are starting to unionize in various parts of the country, another whole topic. But dang, I mean, I know the rules are different than when my husband and I trained and then when your wife trained, but
that's the other part of it. Yeah.
Yes.
Go ahead. Talk about that, because that has an impact on the practice of medicine as well, right? We're already talking about the average patient time. And folks, the phrase I like to use is time is the fire in which we all burn. It's the only resource that is truly finite in this universe. And so, you know, when you add patients to a physician's patient panel, that means less time that they have in the exam room with the patient. That's not a good thing. But I'm sorry, go ahead. You were in the middle of saying something.
Oh no, I guess it's just that, like, you know, back in the day, Steve and I trained at
patient training.
Yeah, Northwestern, and we trained at Northwestern in Chicago. He's actually ear, nose, and throat. And his first year, he had to do internship in general surgery, and it was like, I do have to say, the hours were kind of barbaric. I mean, the poor guy would get out of bed at 5 a.m., like catch the bus down to Northwestern, start rounding, and then he would work straight through that whole day into the next morning, very often not getting any sleep. I mean, I remember one night, like, Steve literally did chest compressions on 2 patients that coded. One of them was actually a member of the U.S. 1980 Olympic hockey team.
My God.
He was like a young person who was on transplant at the time. But like, neither patient made it, because transplant patients are sick. I mean, I don't mean to be saying he did a bad job, but I mean, then like he wakes, he doesn't even go to sleep, then he's still in the hospital, and so works the whole next day and will get home at 8 p.m.
Right.
And then he was like that every other night for 5 months of his internship year.
Sure.
Every other night. So like, that was his cycle. 5 months of intern year, and then the other ones were every third night. So it was just barbaric.
The point in the end, though, right, is both you and your husband doing these we call barbaric, but preparative. It's what doctors have done, you know, for decades, is prepared you for this practice of medicine. It got you up to speed in what the life of the practice of medicine is. Now you've got residents who their hours are severely limited, and they're not trained in the same way that you or your husband or my wife was coming out. I just went through something, not that I tend to get personal on this, but I just went through a situation in which I had a musculoskeletal injury and I had a new family practice doc, and there's a whole long story as to why I changed family practice docs, who misdiagnosed the injury or didn't think that it was as bad as it was. And all I could think at the end was, well, if this guy had had a greater residency time, he had just gone into this practice. Like, if this guy had just done greater residency time, maybe he might have picked up on this a little more. I don't know. I mean, it's all speculative. But my point is, today's post-resident physicians starting out are not trained in the same way that doctors of even 15 years ago were, right? I mean, that's kind of what we're getting at here.
This is what I hear. I'm not part of training residents anymore. I've talked to people who are, you know, the rules and regulations came through. And look, I'm not advocating that
there's got to be a happy medium.
Yes, exactly. I mean, like Duke Medical School, dang. I mean, it was rough. It was raw. I mean, like the surgery department especially, it was tough. I actually did 2 sub-internships my senior year. I actually chose to do a pediatric surgery just because the surgery training was so good. I mean, I put myself on call much more frequently, but I learned so much.
Right.
And so like, that's why I think like the balance is there. Like, you know, is the training as rigorous as it was? And, you know, you brought up too, like the issue with, your wife said, you know, nurse practitioners are, you know, leaving and then they're running off and they're doing, you know, cash pay things like injections and so on and so forth.
Absolutely.
You know, like when nurse practitioners are entering the medical arena with much less than medical students have in terms of training. like the
Right.
number of clinical hours, et cetera.
Absolutely.
And then you're right. Then they're off and leaving into other pastures. So, I mean, we were sold the bill of goods that they would help assuage the physician shortage, but I mean, we shouldn't be trying to replace physicians with anything less trained than a good gold standard.
And then that gets into a really, that's where I was going to go with this, because this is a conversation that my wife and I have all the time, which is, again, there is demand for health care, which is different than health insurance. You get in there, you need to see people. I know my daughter as a scribe does a certain degree of intake on what's going on, patient interviews and things like that. But defining who can practice medicine is a huge thing, right? And my wife and you I'm steadfast in this, and I think this is a good perspective to have. That doctors are the ones practicing. They're the doctors. They have the widest breadth of knowledge, the widest breadth of education. Nurses, nurse practitioners, they have something slightly less than that. Physician's assistants, less than that. I do want to get your take on this move to call physician's assistants associate physicians, which I've got a real problem with. But this issue of how you demarcate who delivers the medical care in the end, where do we draw that line in order to best serve patients?
Well, I like to draw it at transparency.
Yeah,
I like
sure.
a lot of transparency. I'm a sunshiny kind of gal, shine the light, right? I mean, I honestly don't look upon nurse practitioners as practicing medicine. Practice of medicine is defined by our training, right?
Sure.
And our training medicine. I mean, if you want to come along and say you're practicing nurse practitionery, that's great. But one of the problems, you brought up physician's assistants and you brought up, I believe, associate physicians. Some of that is discussed in the same white paper on free, the number
Excellent.
2 in care. So we discuss it in the paper. I could come on again and again and talk about all these
Sure,
things.
Of course.
But PAs actually have a regimented training. Nurse practitioners, there's a set amount of training for PAs. It's less than physicians, right? For physician assistants, there's a set training. Nurse practitioners, it varies as to where they go to school. And one of the big concerning things we've all seen in medicine is the fact that the nurse practitioner training has changed with time. So 20 years ago, you would be maybe a nurse for 15 years, something like that. And then you would decide, okay, I'm going to go to a brick and mortar place and get a degree in the nurse practitioner. So you already had a lot of clinical experience. Nowadays, you have young people coming out of college as nurses, working part-time or maybe even full-time as nurses, and then doing sometimes an online program in the doctorate of nursing practitioner, coming out, putting on a white coat, calling themselves doctor, and then putting themselves out there. Now, does the public know that? I mean, they should. And, so what we say is everyone should have the right to know the degree of training that the person taking care of them has had. But instead, I mean, now it's like, I think it's 24 states plus DC have legislated that nurse practitioners can pretty much do everything that a physician can do.
Right.
And, I think it's only fair that the patient knows the level of training the person caring for them. Practice nurse practitioner all you want.
Right.
I mean, practice witch doctory for all I care. But I mean, I guess I would care, but voodoo dolls and stuff. But I would say, don't say that you practice medicine. And calling yourself a doctor in a clinical situation in that case is a problem.
It's like the midwives and the lay midwives and the doulas and all of these things, who are getting involved in the birthing process. I think that's fine if people understand what they're getting into, but in the end, right, it's not the same thing as having a baby in a hospital, in that kind of a setting where you have a doctor delivering the baby, or even a certified, nurse practitioner delivering that baby. No, I think you're right there. And this is something, again, that my wife and I discuss, is this problem of folks going to online nursing schools who have no clinical time, who then step in there and it is just a mess, in that clinical setting. That's a real issue. But clearly we need to sort of wrap our heads around this. Let's come back to the medical school issue. And let's assume for a moment that we do solve the issue of residency programs. we need more medical schools and medical school births in America, don't you think?
You mean medical school positions by births? BERTH?
BERTHSs. Yes, that's what I meant. Not BIRTH. Thank you very much for that. I appreciate that.
Well, if we're going to dial back the physician shortage, I honestly, let's cut the glut of regulations to at least free up the physician time, right?
Sure.
And
right.
then
That's a good point.
Yep. We could use more opportunities there's actually roughly 12,000 medical students that go unmatched in residencies per year.
Right.
So we need more training positions,
So I'm sorry, say that again, because I don't want to bury, that's a lead that we're burying there. 12,000 medical students when they graduate, how they go unmatched?
I think it's somewhere between 8 and 12,000. It varies each year, but they go unmatched.
10,000. So that's 10,000 folks who've graduated from medical school who are not in residency programs. And, just so that my listeners and viewers understand, the number of residency programs has gone unchanged in the last 30 years, right? It's 30 years since we sort of changed that formula. And yet the population in America has risen dramatically. We now have new laws that give people health care that didn't have it before, but we've done nothing on that residency side of things. But again, actually, let's go back to what you said about regulation and paperwork time. Because I know when my wife is done with her day of work, and actually I used air quotes I shouldn't have because she is working, but she's done with her day in clinic, she still has another 2 to 3 hours of paperwork that she's doing at home or at the office. How much time do we know how much time doctors are spending that could be cut back doing paperwork to meet somebody's mandate somewhere?
Click, click, click. Death by 1,000 clicks, right?
Yeah. Right.
Take your pick of click. What clicks should we be getting rid of? I mean,
that's a question. Yeah.
Yes, some are pointing out prior auth. There's good bill, the seniors' timely access to care, that at least for Medicare Advantage, which, there's problems there too, and we could talk about that all day. But at least for Medicare Advantage, they're trying to streamline the prior auth process, because currently physicians, I think national average is 14 hours a week per physician is spent on prior auth paperwork. Not all done by the physician, but sometimes they just have to hire, big offices, several people are there just handling prior auths. I mean, I had a friend who worked in a medical office and told me that the prior auth person was just literally throwing things at the wall because it's so frustrating.
No, I just was going to say, I mean, it's all about, and a lot of this is understanding the language and being able to put in the right language. For me, with the injury that I got in April, my doc put in an authorization for an MRI. I needed an MRI. But didn't word it properly. So all of a sudden it's taking me 6 weeks to get an MRI and an injury that needed to be diagnosed within hours, not weeks, and would not change it, which is also insane, but set that aside. But I mean, so you have the folks who have to know the language, and that's crazy. But anyway, you're saying, so who do nothing, these folks in these offices who do nothing but the prior auths, that's time that a physician could be spending doing diagnostic care. Go ahead.
Yes. I mean, there's lots of the paperwork kind of stuff that's government mandated, or boxes that you're supposed to check to prove that, you're a worthy person to provide care for Medicare and Medicaid, so on and so forth. I mean, 2015, they passed this, it was called MACRA, Medicare Access and Chip Reauthorization Act. Sure. And within MACRA, essentially, that was back when I think they were, the sustainable growth rate. They were repealing the sustainable growth rate so that physicians supposedly would get paid or at least not get cuts. They were supposed to get 24% in cuts by that point. And then there was another 300 pages saying, these are all the things that you have to do to prove to us that you're good little boys and girls giving good quality care in Medicare. I mean, I get that, I get that the government is paying physicians through Medicare. I understand that people have paid into Medicare, but there's kind of almost a false promise here, right?
Right.
Because,
Absolutely.
And you go to these conferences, and I'm just not a beat around the bush kind of girl,
Wait,
I went to this, right. I know everyone is shocked. I went to this Wharton Healthcare conference once, and they were doing something where they were talking about this, the MIPS within MACRA, the incentive-based merit incentive payment system. Like you get paid more if you check all the boxes or do all the things you're supposed to hold. So like I raised my hand, like this is the after lunch lecture, and I'm like all paying attention. And it's all these like people from CMS are up there on the stage, and I raise my hand and I'm like, yoo-hoo, I have a question over here. Everyone else is snoozing. And I'm like, hey, I get it, guys. You need us to prove that we're doing good quality things so that we can get paid. But like, what I'd like to know is like, all you guys at CMS, how much money did it take you to plan, launch, and continue to implement this like MIPS program? And y'all have any proof that it's actually beneficial to anyone?
Right.
And like, it was like, here was these guys up here. Like you can get this part on video. And by the way, if you're seeing this part on video, I'm in my workout gear. I just finished a boot camp. But anyway, so they're all looking around. They're like, who's going to answer this question? It's like, no one wanted to answer. And finally, one sheepish guy, I still remember he had red hair. He like, well, I'm not sure how much we all paid. It might be on the website, and we're hoping in a couple years there will be some evidence that there was.
Wow.
Yeah. And like, so I'm like, let me rephrase for this audience here, who now is awake after lunch because of the question. I'm like, to rephrase, you don't know how much of our tax dollars you've spent to put out a program that you have no proof actually really helped, and you've made me and other clinicians have to go click, click, click by 1,000 clicks. I mean, this is the kind of stuff we're talking about when we're talking about how the government unrolls what they call, quality and, all the rest. So
sure, somebody had the idea and they said, well, we're not going to focus on the fundamentals, right? We're not going to focus on increasing the number of residency programs. We're not going to focus on these other things. So let's try this as a way of going down that road. I spent a lot of time talking about why we are supposed to have a deliberative public policy process. Let's shift gears a little bit, because part of the reason why you and I started talking was I was talking about pharmacy benefits managers, the PBMs problem. It's something you and my wife could spend hours talking about. But, this issue of PBMs, and again, talking about transparency. Well, first of all, for my listeners, why don't you tee up what PBMs are and talk about why they're a problem?
Oh, Lord, love a duck. Could I go on forever?
Go into detail. I mean, you're welcome to go into detail.
Yeah,
this is
sure.
The point of the conversation.
So remember when I told you, like, I sort of woke up Rip Van Winkle style, the kids were like grown,
right.
And I'm like, okay, it's the economy, stupid. Where's the money going? Because we're all paying more and getting less. And, doctors are making 7.4 cents in the healthcare dollar. Not that anyone trusts, there's a lot of people that don't trust us anymore after that COVID mess, but that's another story. But like, so there I am, and I'm waking up, and then I ran right into these pharmacy benefit managers, and what they are is they're a middleman. All right. Like, so the pharmacy benefit managers, they pretty much have lock, stock, and barrel control over the entire outpatient prescription chain.
Right.
The pharmacy benefit managers, PBM, we'll call them PBMs right now, they create the formularies. That's the list of drugs that are covered by your insurance company. Over time, in the last several years, the pharmacy benefit managers got bought or merged with big insurance companies. So now the three big PBMs that control 80% of all pharmaceutical purchases in the United States, CVS Caremark, owned by CVS, who also owns Aetna, how convenient. Optum RX, owned by United Healthcare, and Express Scripts, which now calls itself, I think, Evernorth. They change their names when they get caught doing nasty things.
Sure.
And like they got bought, Express Scripts got bought by Cigna. To put into perspective the amount of money that PBMs make, and we'll talk about how they do it in a minute or two, when Cigna purchased Express Scripts, their revenues tripled.
Yeah.
Did your listeners catch that? You're an insurance company and you buy the PBM and you triple your revenues.
Sure.
Everyone thinks the insurance company makes all the monies, but I always call these PBMs the cash cows.
Right.
Well, how does making a formulary create a revenue stream for you? Well, it's not just the formulary. The PBMs were granted by the government. My gosh, the government, like, could we please just accept the fact that they will not, or they have not by and large done the right thing in healthcare?
Sure. 100%.
The government gave them the right to receive kickbacks.
Yes.
Yes,
Yeah.
2003. Someone in CMS, HHS, whoever it was, same year they put out Medicare Part D prescription plan, which is probably no small coincidence, I don't think, but whatever.
Interesting.
So when they can receive kickbacks, that means they can take money from the pharmaceutical companies, and then they're the ones making the formularies. Well, how is this not related? You can just buy your way onto the formulary.
Right.
And so
hold on for a second. Hold on. Because it gets back to the issue of transparency, which is what you've been talking about here. I'm sorry, but so it would be great if America would understand this. This is why we're trying to expose this. Go ahead. So, yes.
Yes. Yeah. So, essentially, the pharmaceutical company and the PBM can have these deals. They don't call them kickbacks. They call them rebates, right? Yes. Which is really irritating. Yes. Another piece that I wrote last summer, Senator Marshall and Senator Mullins from Oklahoma, or Mullen, I can't remember if there's an S or not at the end. They kind of teamed up when they were grilling the PBMs, and what they got at was, Mullen was like, wait a second, y'all say you collect rebates, but I take my kids to the ER and am I getting any of this rebate money?
Right.
And
right.
Marshall was calling them kickbacks. It was beautiful. I loved it. And the PBMs revealed that they always say they pass through these rebates, which are actually kickbacks. They pass through them and they pass them through to the patient. So the patient's getting the benefit. But I don't honestly know of anyone who thinks that prescription drug prices are going down or that their healthcare costs are going down and these guys are making money. Turns out they were passing them through to their offshored, some of them are offshored companies called GPOs. And GPOs are the only other entity that I know of allowed to accept kickbacks. So, so this is only one revenue stream, mind you.
Right.
And these PBMs, they're like the cartel because they not only so think about it. I just gave you CVS as an example.
Right.
CVS a couple years ago bought Aetna because they had $62 billion lying around, in part because they had, a lot of money coming from their PBMs. So they buy Aetna. And so the insurance company, the other thing the PBMs do is they get money from their associated insurer to cover the prescription. Yes. So Aetna pays their own PBM the money that they're supposed to be paying to the pharmacy.
Right.
Right. Now, if you think about it, if you're all a big conglomerate like CVS, which owns the pharmacies themselves, and Aetna and the PBM, you're incentivized to pay more to your pharmacy that you own. And in fact, the independent pharmacists have been screaming this from the rooftops and have very successfully, I might add, gotten to people in Congress and pointed out that independent pharmacies are closing. I think we closed 140 pharmacies in Pennsylvania, most in rural areas, since the start of this year.
Right.
So, this another revenue stream for them is they can just money launder, because it's like money laundering, right? They're taking their money, paying it to their own inpatient pharmacy. And another whole thing could be like the medical loss ratio. Remember?
Where did you grow up?
Me? Oh, I grew up right here in Bucks County.
Okay. Do you remember, I think you and I are roughly, I think we're roughly the same age. Do you remember an electronics store called Crazy Eddie when we were growing up?
Oh, yeah. I can still hear the commercials. Eddie, the
prices are insane.
Yeah.
So that was, one of the things, as I recall, the reason why Crazy Eddie eventually closed is because they were inflating their revenue numbers because they were buying their own product. And it was like a whole thing where they were sort of pushing up their apparent sales to the public by buying their own products. And then anyway, it was a whole thing. That sounds like what's going on here is that there's a massive sort of inflation. There's a circular argument that's going on here. As you said, it's laundering. It's money. It starts with the patients who have to pay in, or the government paying into the system, and then they're buying. Anyway, I'm sorry. So it's very, very circular here in terms of how they push this up.
And then what they do is they also own something called specialty pharmacy, which is specialty drugs are not very well defined.
Yeah.
They have different definitions in different parts of the country, as it's explained to me. But specialty drugs, by and large, tend to be the drugs that chronic patients take. They tend to be newer drugs. Oftentimes, they're injectable drugs or IV drugs. They're usually drugs for cancer, MS. They can be drugs for other rheumatologic problems or endocrine problems. They can be hormone blockers, right? They can be all kinds of things. But the specialty drugs, by and large, tend to be more expensive drugs. And I told you about the kickbacks that the PBMs take. The cost of the kickback is usually a percentage of the cost of the drug. So the PBMs are incentivized to get more kickbacks, to get more money. They're incentivized to pick a more expensive drug. And their parent insurance companies don't care, because if you're paying attention, underneath Obamacare, there was something that sounded good but turned out to be bad. It's called the medical loss ratio.
Yes.
Elizabeth Warren is waking up to this too. There was like a piece somewhere in Wall Street Journal about Elizabeth Warren and the medical loss ratio, because what insurers are supposed to do, the big ones at least, 85% of what they take in as premiums is supposed to be rolling to either patient care or quality measures, right?
Right.
And so if they're paying more for drugs, they're paying they're giving the money to their own PBMs to give to their pharmacies, their medical loss ratio, that 85% number, is higher. Right. And then that means that the 15% that they have to pay their fat cat insurance, suits, the people that run the show, is also higher. If your raw number 85% is higher, your raw number 15% is higher. Right. And they don't care. They're incentivized to spend more, so the fat cats keep on getting fatter. I mean, I don't understand why people don't get this. But then it gets worse with the new bill the new law, actually, that we now have in Pennsylvania. Right. Did you want to talk about that? I know we don't
100%, please. Go ahead.
Oh, yeah. I wrote a piece in Delaware Valley Journal. It's a wonderful journal. Very independent. They had asked me to write about PBMs. And once again, let's interject some real life so that people hear how we go around here. I've recently, my husband and I recently become empty nesters. So we had last kid, getting ready, move out, all that stuff. Right. I'm busy doing life stuff one day. Right. And then I got a call, from legislators in the Pennsylvania State House who know that I know this issue. They said, Marion, this PBM bill, 24 hours ago, they changed it in the Pennsylvania Senate. And these changes, there's a lot of changes. I'm like, what kind of changes, right? Well, number one, they were going to get rid of something called spread pricing. Could be another whole discussion, but the bottom line is spread pricing is more legal thievery for the PBMs. They're pretty much just, they get the money from the insurance company. They give whatever they feel like to the pharmacy, usually less to the independent pharmacy, and then they keep the difference. That's what spread pricing is. It's poof, in the last 24 hours before it was voted on. Also, they were supposed to ban PBMs from being able to steer patients to their own pharmacies. CVS Caremark, the PBM, couldn't steer the patient to CVS pharmacies. They made multiple exceptions for this. They allowed exceptions for the specialty drugs, and then they defined the specialty drugs. And the way they define the specialty drugs, bottom line is, it's going to be the most expensive drugs that have the exception for steering. And then there were other things that happened in this bill, but the thing that I found notable and concerning as a pediatrician is this. They allowed pharmacists to be able to give injections of biological medications, many of which could be defined as specialty drugs probably, down to age 8. Age 8. Now, what's interesting is they were talking about pharmacists giving vaccinations down to age 3 or 5. And there was stuff going on there. And they were talking about pharmacy techs doing various things down to age 13. Now, why all of a sudden are you saying you can give biological injections down to age 8? Well, you cannot argue that this creates a perverse incentive for hormone blocking to be given in your local neighborhood CVS. I mean, there's some hormone blockers that are given either as a 3-month depot shot. They can also be given as implants, or they're given sometimes monthly. And age 8 jumped out at me. Now, even if you are of the mind that thinks that an 8-year-old child should be able to make the decision that they're born in the wrong body or born with a different gender than they wish that their chromosomes intended, even if you're of that mind that it's a good idea to start medications that course through the body on a daily basis, even though they might be given monthly, even if you're of the mind that this is the only thing to do, that this is a chronic disease that's life-threatening, that, this may be a child that would kill themselves, even if you are of that mind. Now think about everything else that I just told you, because this means that CVS Caremark can choose a more expensive version of whatever hormone blocker there is, collect a bigger kickback, put that on the formulary.
Right. Get it. Yeah.
If your listeners look up NPR and histrulin acetate, which is it's the blocker that blocks female puberty, they'll find out that there was a father whose child had precocious puberty, which is one of the reasons you need to give histrulin acetate medically.
Yeah.
And he was frustrated because he had all these big copays. He had a big deductible. And he's like, I don't understand why my insurance company was making me use a $37,000 medication when there was a $4,000 medication available.
Right.
And he couldn't win the battle. Well, I understand why they were doing that. They could be doing this for the medications that they're using to block puberty for those who want to attempt to change what their gender appearance is as well. And so they pick the more expensive medication. They collect bigger kickbacks. They pay the more expensive money to the pharmacy. The pharmacy is able to use that because they're able to steer towards CVS. And now you have a pharmacist giving the drug. Well, also in the last 24 hours of this Pennsylvania bill, they changed the transparency. I explain it in this piece in Del Val Journal. Yeah. But they changed the transparency to where it's completely watered down. I mean, you want to go into the specifics. What they did was, instead of taking a look at an individual patient for an individual drug or an individual employer, etc., essentially you're only going to announce what those rebates are in aggregate.
Wow.
So, yeah. So like these rebates that I've been screaming from the rooftops, my gosh, when I first heard about this and the kickbacks, I thought, oh, I'll just go tell Congress and they'll be like, oh my gosh, look at all this money. We can save money. We can fund, new residencies. We can actually, help mental health crises. We can help addicted people. We can help people with cancer, and it's been dragging them kicking and screaming.
Oh, absolutely.
But whatever the case, so the transparency, it's completely controlled by the Pennsylvania, insurance, whatever it is, the person who's in charge.
Yeah. The insurance commissioner. Yeah. No, Ed, Maryland, yes. Same thing. Yeah. I get it.
Yeah.
Let's shift gears because you did send me an article this morning that also disturbed me, which is this, and I want to say it's from no, it's not the Daily Caller.
Washington Free Beacon.
Washington Free Beacon about doctors and medical facilities now getting into the business of registering people to vote. I mean, this is, again, crazy given what we're all doing. I mean, obviously we know why they're doing, but we'll talk about what's going on here. What do the Free Beacon have to say?
Yeah. Okay. Well, so first of all, let me say, there's actually a very robust discussion going on Twitter right now. Like, a nice, a very ethical doctor, I think, seems very ethical, writes in something called Sensible Medicine. His name is Dr. John Mandrola. He kind of brought up that, maybe physicians shouldn't be discussing politics. And I think he meant maybe they shouldn't be discussing it with patients. And what I would say is like, when we're in a room taking care of a patient, we have to be focused on the patient. We shouldn't be focused on politics.
Absolutely.
I do think that given the state medicine is in, if we don't discuss policy and how policy is formed and made, as long as we're being open and honest and transparent, and like I used to say to my kids, if you're going to have an opinion, go have your opinion, but be polite about it and be able to back up your opinion.
Oh, absolutely.
Don't diss the other person, and I think all will be well. Right. And I think the same thing about physicians talking about policy. Like this recent hearing at the Oversight Committee on PBMs where they were grilled, and it was beautiful. There were both Democrats and Republicans saying the same things. Right. I mean, I watched a recent budget committee hearing with Jody Arrington and oh gosh, the guy's Brendan Boyle.
Yeah.
And it was about monopolies in healthcare.
Right.
And in healthcare, there's great potential for us to agree across the aisle. We should be agreeing on the economic aspects, like don't allow kickbacks, cut the glut, things that we're all talking about. But what you brought up, the Washington Free Beacon article, a group formed, it's called, I believe, Vote ER, voter, but the
Vote ER. Get it. Very clever.
And they state that they're bipartisan, nonpartisan, one or the other. I can't remember which. But when you dig into the group, the Free Beacon article pointed out that they seem to lean heavily left.
Yeah.
And it looks as though they worked with the AMA to get a resolution passed. And that resolution was allowing voting to be called a social determinant of health. Now, maybe it is, maybe it isn't. But the reason that this is kind of important is because the AMA created a bunch of codes for social determinants of health.
Okay.
So doctors, when they have social determinants of health appear in front of them, they can code that in their patient's chart by their code.
Meaning what? What would an example of another social determinant? If someone smokes, income level.
Yes, a zip code, lack of access to food deserts, things that are very real.
Yeah.
I mean, really,
I get
truly.
it.
No. I mean, I'm not arguing those things exist, but the deal,
agreed.
Where we'll go with this, or where I always wonder if the AMA is going. The AMA, whenever something new or big is happening, they create codes. It's almost like a bat signal. Let's throw the bat signal up into the night sky. And, but the AMA, for their codes, they collect royalties on the codes that they make. Now, these are different codes than the rest of their CPT codes. I mean, these are Z codes that are associated with some of their CPT codes. I don't know what the money stream is on that.
Wow.
But the fact that the AMA makes money and royalties off of codes that doctors need to use to get paid by insurance, there's a giant conflict of interest in
massive,
itself. Yeah. And now that they're creating social determinants of health code, if you're putting SDOH codes into a patient chart, look at all the hacks that we've had. This is very sensitive information.
But let me take the next step here. So, but when you talk about the political leaning, so literally the AMA is they're talking about if you vote Republican or Democrat, that should be coded as a social determinant of health?
I can't say that.
Okay.
I think what they defined as the ability to vote as a social determinant.
Oh, I see.
I'm questioning, are they making money off of those codes, the SDOH codes? And are those codes really stable and safe for the patient, like the patient's private information? But let's go one step further, because this group, Vote ER, that claims to be bipartisan, worked with Epic. Epic, as your wife probably knows, is the biggest.
I know it. Yeah.
What is it? Software, I guess.
It's software. It's a platform.
Yes,
it's
exactly.
A platform of patient information. Yeah. Yes.
Yes. Founded by someone that is a enormous Democrat donor, and at the time that the HIT Act that mandated computers was coming out, this particular woman was on the Obama's healthcare IT team, another big conflict of interest. These conflicts of interest are everywhere in medicine. But Epic was working with this group, Vote ER, such that it looks like physicians are able to have the discussion and then enter into the Epic chart, at least. I don't know if they're doing it for Cerner and the other platforms, but enter into the Epic chart whether or not the patient is registered to vote. I have no idea what other information they're entering, and we honestly should know that.
Yeah.
Are they entering particular parties, ways that they vote, what their topics are, what they're interested in? Because
again, I'm not sure why this is a social determinant of health, right? When there are other things out there that are, education levels, income, zip code, as you said, do you live in anyway, that is crazy. And they're also taking the next step, right, of giving them opportunities once they're coded in, right? They have a QR code that they can scan to go and register to vote.
Well, I think that people that are members of Vote ER have a QR code so that they can, have the patients register.
Wow.
Now, this is a time during which you're having a conversation with your patient who may be vulnerable for whatever reason. You have potential political capture, is how I'll put it, at a time when you should be talking about medicine. I guess some doctors are arguing, well, my patient's ability to get medical care would depend upon how they vote. Well, it depends upon how you look at it.
Right.
Like, are you, I honest to God hope that physicians are not trying to push patients to vote in a particular way. I mean,
yes.
And lastly, then the other problem here is like, if you're creating codes and you're able to monetize the codes, and everyone knows data is king, and that data would be very valuable to someone. Is someone selling this data?
Right.
Because if you're collecting this data and then you're selling this data, my gosh, this just feels very unhippocratic medicine to me.
I agreed wholeheartedly, and these are all important questions. Listen, we're running short on time. I always ask my guests this because I know my listeners are interested in it. You and your husband, you're now empty nesters. I know you're both practicing physicians. What do you do with your free time? What are some of your outside interests?
Oh, I'd love anyone who's listening, if they want to follow me at @Mass_Marion on Twitter. Okay. I'm a massive organic gardener.
Okay.
And I am very into healthy cooking. Like if I said that I had a specialty in cooking, it would be, how do I make healthy food taste good? And especially vegetables, right?
Oh, yeah.
I mean, so I put up pictures of my garden and my food, and recently I've been doing pictures of my tomatoes. I'm starting a new project with a group called Physician Outlook.
Okay.
And I've started to film some of my cooking, and eventually I'll be filming parts of my gardening. That's wonderful.
Yeah, well, film me cooking. I'm cooking healthier now because I've been dieting for the last 4 months. Do you have a favorite tomato variety? Like for me, I'm a big Mr. Stripey fan.
I love Mr. Stripey.
Yeah, there we go.
So the garden has been going on for 21 years, as long as we've been in our house. And I've grown probably maybe 80 different tomatoes right now. I love green zebra.
Oh, yes.
I love black from Tula. I have a new one this year called pineapple, not black pineapple. I've done black pineapple, but pineapple.
Okay.
That one's fantastic. And then if people like cherry or grape tomatoes, there's a little tiny, like almost white yellow one called Coyote. I start my tomatoes by seed, but I don't even have to plant Coyote because it's guaranteed to come up as a volunteer in the garden.
There you go. That's excellent. Well, listen, Marion Mass, Dr. Marion Mass, you were the co-founder of Practicing Physicians of America. Thank you so very much for joining us today.
I'm delighted you had me. Thank you.
Thank you. We'll have you back, and we'll have you on the radio too. This has been yet another episode of The Lunch Hour with Federal Newswire. As I've said, please, if you're watching us on YouTube, you can check us out on those fine podcast platforms. If you're listening to us, you can go check us out on YouTube. Leave a like, leave a subscription, or get a subscription. Leave a comment, and let everybody your friends or family members, your family members' friends. Let them know all about The Lunch Hour. I'm Andrew Langer. Enjoy the rest of your lunch.
This has been the Federal Newswire Lunch Hour Podcast, hosted by Andrew Langer. Check out the Federal Newswire's family of websites, as well as their social media stream.